So we need to launch this and this. Whoops, all the way to the beginning. All right. Hi, everybody. This is awesome. Like, everybody in the med school wants to do IR, so this is super exciting for me. My name's Mollie. I'm the program director of Interventional Radiology here at UAMS, and I'm going to talk to you guys and apparently the interwebs about what IR is and how medical students can learn more about IR and get involved in IR. So I'm going to talk for 20-30 minutes, and then we'll have time for questions, and Paige and Jordan can answer questions about some other stuff. So this is kind of a free-for-all. Feel free to just raise hand and ask questions. And if you can't hear me, let me know. So the first thing is, because there are other people across the country listening, I thought I would show people where Arkansas is. Because before I moved here, I didn't really think about Arkansas ever, and it turns out it's a spectacular place with lots of wonderful things to do and wonderful people. So here we are down here with the pig and the flowers and the riverboat. So this is what I'm going to talk about today. Can I make this go away? I don't want to quit it. Can I just hide it? What if I do this? There we go. I'm going to talk about what IR is in a very basic sense. I'm going to talk about why I love my job and am not miserable when I get up in the morning and leave to go to work every day. I'm going to show you some resources to help you guys learn more about what we do. And then very, very briefly, I'm going to talk to you about the training programs. It can be really complicated. So I'm just going to give you a quick overview, and we can talk more about training programs at a later date. And this is a picture of our campus. For those of you who aren't here, we're a 450-bed hospital. We're the only liver kidney transplant program in the state. We're the only trauma one center in the state, and we are the only comprehensive stroke center in the state. We are also a regional HHT center. We have a giant NICU and complicated maternal fetal medicine program, and the Children's Hospital is just up the street, which we have a really good relationship with. So you guys have a ton of resources here and lots of great people and specialists to learn from. Click. Why is my thing not going? All right, I'm gonna have to click on it. All right, we're gonna watch a little video because this is the best description of IR I've heard.
Incision in the skin, interventional radiologists deliver precise, targeted treatment. Life-threatening conditions such as cardiovascular disease, stroke, or cancer are treated less invasively than ever before. This often reduces risk, shortens recovery times, and improves patient experience. All key metrics promoted in alternative payment models.
Without the interventional radiology, I probably would not have survived.
I came into the hospital with a massive, potentially lethal pulmonary embolism. The interventional radiologist very quickly came in, treated my clot. I was out of the hospital in 2.5 days and back doing my exercise regimen in 1 week. Just incredible.
You've demonstrated over and over in interventional radiology that we're efficient, we're fast, we're effective, we provide quality care and low cost. That's really the holy grail of modern healthcare.
Interventional radiologists provide longitudinal care for patients. They also work with other specialists, delivering innovative solutions to today's toughest medical problems, often at lower cost to patients and healthcare systems.
These techniques allow patients to have safer procedures that are less costly, that get them back to work quicker, get them back to their daily lives quicker.
Our practices are uniquely positioned to generate tremendous savings to hospitals, medical groups, and radiology practices, particularly as alternative payment models start to evolve and become more common.
Interventional radiology improves healthcare by developing, testing, and implementing breakthrough medical treatments. Hospitals can leverage interventional oncology to take part in research opportunities, including the government's billion-dollar Moonshot Cancer Cure effort.
Interventional radiologists are participating in innovative research where we can deliver targeted treatments directly to the tumor.
Interventional radiology is a primary medical specialty. IR residency programs now accept interventional and diagnostic radiology residents. Doctors who complete this training can be board certified in both diagnostic and interventional radiology. These steps will increase the current IR workforce to fuel clinical practices nationwide.
I think it's important to be ahead of that curve. I think it's important to invest in the future. And I think it's important to do that because we want patients to have the best outcome possible.
As administrator, I think IR has the potential to deliver tremendous value to our healthcare enterprise and particularly to patients.
Okay, so that video was published by our International Society and by the Diagnostic Radiology Society because, oops, that's not what I want. Because lots of administrators, lots of other physicians don't know what IR is and certainly don't know how effective we are at reducing hospital costs, shortening length of stay, minimally invasive procedures that don't require anesthesia. There's a lot of things that we do that are real game changers for medical systems as a whole, which everybody knows money is super important these days. So this is sort of what is interventional radiology. We are like surgical subspecialists, except we're part of radiology instead of surgery. We do diagnostic tests and we take pictures of things to give people diagnoses, biopsy things, and then we do things to treat tumors, treat blood clots, treat all kinds of things. This little man here is from the SIR website, and this is just a tiny snapshot of all the different kinds of procedures we do. So, and it's what's nice about this is if you're interested in any particular body part, we are monkeying with it. So we treat stroke, we treat compression fractures in your spine, we treat lung cancer, we treat hemoptysis, which is when you cough up blood, we treat blood clots in your lungs, we treat blood clots in your veins, we treat blood clots in your arteries, we treat vascular malformations, we take care of dialysis access and hemodialysis catheters, and when the surgeons put the shunts in, we help clean those up and keep those working. We do a lot of work with kidneys, livers, treating cancer, treating obstruction because of stones. There's basically any body part you can name, we somehow touch it or are involved with it. So interventional radiology started in the 60s, and this guy's name is Charles Dotter, and I have never met him, but the people that I know that knew him say he was as crazy as he looks in this picture. This picture was taken from Life magazine. So he's the father of interventional radiology. And way back before everybody had CT scanners and MRI even existed and everybody had ultrasound machines, radiologists diagnosed your disease process by taking pictures of your blood vessels. So we would put a little tiny tube in your artery to your kidney, squirt dye in it, and say, yep, he's got a kidney cancer. Now you just go get a CT scan, you'd be out in like 30 seconds. So Dr. Dotter transformed that taking pictures from just taking pictures to fixing things. And his first sort of transformation was dilators. So they look like, kind of like this pointy, slender thing. And he made them different sizes, bigger and bigger. And he said, well, if I can put a catheter in an artery and a wire in an artery, I can slide this little thing in there and stretch the artery out. And that was sort of the beginning. And then some other people, a cardiologist and a German guy, a whole bunch of other people got together and they just, it expanded. They started making balloons that you could blow up and these little stents that look like slinkies that you could sort of spring open and hold things open. And that's how interventional radiology went from diagnosing disease to treating disease. This is what one of our IR suites look like. This is a biplane room, so this is a room where we would do a lot of neuro work. This is one X-ray camera here. This is another X-ray camera across here, so you get two views of the brain when you do this. This is the patient's head. Here are our screens where we're looking at all the pictures we're taking. These foot pedals down here control everything. And then this is me and then one of the neurointerventional radiologists. So now we'll move on to why my job is so spectacular. One of the best things about my job is that there is always something new. You don't ever get tired of doing the same things over and over and over again. An example of this is something, I'm going to show you a couple examples. This is an angiovac. This is a shock vac for your veins, basically. It is huge. It's about as big around as kind of a fat pen, maybe a Sharpie size in diameter. It has those little flares on the end. You stick this up in somebody's vena cava and you turn on the shock vac and you suck out clot. It's absolutely amazing. And this did not exist when I trained. I just learned how to do this last year, which is awesome. This is a hunk of stuff, some old clot fibrin sheath that came out of a patient's right atrium. And this is the other stuff that was attached to it that came out of the superior vena cava that was part of it. Prior to this, the way to get this out is to split the patient's chest open their heart, take it out, sew it all back up. And we did this in like 2 hours. I mean, it's what's so great about what I do. This is a radioembolization box. Right when I finished training, started doing Y90 radioembolization, which is when we put really high dose radiation beads into people's cancer in their liver. So it goes just where you put it. It treats only that little tiny area. And we do this as an outpatient all day, every day. And we've completely changed the way our transplant program works because we've got people who can stay alive longer while they're waiting to get their livers. And this is probably the most nationwide changing medical device development that has come out of IR that is going to have a huge impact over the next 10 or 20 years. This is a clot retriever device for your brain. So imagine this is a teeny tiny artery that goes up to your middle cerebral artery or a branch of your middle cerebral artery, and you have a stroke. So we put this little thing up there, it's called a stent retriever. You open it up, it sort of grabs a hold of the clot, and then you suck it out. And this is an example of the clot. And as you can see, it's teeny tiny. This thing's about the size of a dime. But this little tiny clot can stroke your whole right hemisphere and you won't be able to talk or walk or do all those things anymore. And now we can just pull it on out. So the other thing I love about what I do is that I do different stuff all day, every day. It's a wide variety of procedures and different patients, ages, all kinds of things every day. So on Monday, the things I'm going to show you are all stuff that we've done in the last 2 days, and all of this stuff I did Monday. So this is a girl with hereditary hemorrhagic telangiectasia, or Osler-Weber-Rendu, I don't know how they're teaching it to you now, which is an autosomal dominant disorder where you get tangled up blood vessels. So this is a picture of her lungs, and this is a pulmonary AVM. So Monday morning I came in, I fixed her pulmonary AVM, we closed that up. And then this is a patient who had a gallbladder surgery gone bad. So this patient had a hole in his bile duct. So we had to put new access in through his liver to drain his liver and take this ERCP stent out and cover the hole. So this is what it looked like when he came. And this is what he looks like an hour later. And then after that, I did a fistulogram, which is where I fixed up a dialysis access on a patient that wasn't working very well. This is the artery, and this is where the vein is sewn to it. And there's a lot of little lumpy, bumpy narrowings in here that we put a balloon in and popped open. And then we did some work a little further up. And then in addition to this, I did a whole bunch of little stuff, central lines, I ports, G-tubes, access drain, biopsies. So it's like all different body parts all day, with some really interesting cases in the middle and some more routine stuff. The third reason that I love my job and I love being involved in IR is all the different kinds of people that I get to meet and interact with. It's not just me and my partners. I spend more time interacting and talking with all the other subspecialists and physicians in the hospital probably than I do interacting with the people that do the same thing that I do. My patients, so I have clinic once a week. Just like a surgery practice, I see clinic patients once a week, and then I do procedures the rest of the week. So this is a family, they have HHT. 2 of those people are twins, and I've been following them since they were like 5. I know all about their lives. I get college pictures from them, and that is so rewarding to have longitudinal care and see what happens to people and follow them long term. I really enjoy that opportunity. This is one of our transplant surgeons and his wife. We are a huge part of the transplant program and the transplant team here. And so it's really an honor to get to work with people that are so smart and inventing new things and participate in the invention of those new things. And there's all kinds of creative collaboration that goes on when you branch outside of just your own people all the time, every day. And then teaching is always a wonderful part, and part of why I'm in academics is because there is almost nothing better than teaching somebody a new skill or how to solve a problem for a patient, and seeing them when they're first learning and struggling up to when they can actually like put the central line in and the patient walks out and the patient says, that was great. And you know, you guys feel good and the patient feels good. It's like, it's a wonderful experience teaching. So this is Dr. Culp, who is one of my mentors. He is working really hard on continuing the revolution of stroke care. He has a bunch of NIH funded grants. And so he was one of my mentors. And then this is Kristen, who graduated last year, who's gonna do IR in Dallas. She's doing her intern year here now. It's just, this is from graduation, and it was great. We had a good group of people last year that graduated and went into IR. The best part of what I do is that it's seemingly very small. The little tiny things I do make the biggest difference for the patients. Sorry. So this is a patient that actually Paige, who's a 4th year med student that's rotating on our service, she actually took care of this patient on either Friday or Monday, I can't remember. So this is a CT scan. This is his backbone. This is the right side of his belly. This is the left side of his belly. This is the bottom of his liver. Right kidney, left kidney. This giant puddle of goo here in the middle has air, which is this black stuff, fluid, which is this grayish stuff, fat, which is this sort of darker gray stuff. This is like a necrotic pancreas with infection in it. This is a terrible, terrible problem. So Paige and I, in the CT scanner, Paige did 99% of the work, put 3 drains in this guy and got 3 liters of the most repulsive, disgusting, dead pancreas infection stuff that you could smell like all the way down the hall. But literally a day later, he's completely changed. He's not septic, he feels better. And the alternative to this is an enormous surgical operation. So what Paige did in 20 or 30 minutes worth of work saved this guy, you know, days and days of misery with an open belly and a bunch of stuff. And this is like super easy. This is routine. This is something that we can do sort of with our eyes closed. Same for this. This is an eye port. So here's the patient's heart, spine, right clavicle, left clavicle. This is just an infuser port. We make a little incision, it goes in under the skin. It's used to give chemotherapy, draw labs, give blood products. It takes me 15 minutes to put this in a patient, and it completely changes the person's life because now they don't have to get IVs all the time, they're not getting poked all the time. It's the little things that make a huge difference that as I get older have become more and more rewarding. When you're first learning, the little things are exciting. And then you go through a period where you're like, if I never put another central line in, it will be a day too soon. And then you sort of come around the other side and say, it's the little things that make the biggest impact. And those things are so easy and so safe when we do it that it's just amazing. So any questions about things that we do or things that are spectacular about IR before I move on to showing you what resources are available? Okay. Oh, yeah.
So you said it takes less time than surgery. Is it also cheaper than surgery for the patient? Like,
usually, yes.
Dr. Meek, can you repeat the question?
Oh, yeah, sorry.
So they can hear you online.
So what she asked is, it definitely takes less time and is less invasive, but is it cheaper? In general, yes. There are a few studies that compare cost for a couple of things. I'm sure it doesn't surprise you that figuring out cost in a big system like a hospital is all smoke and mirrors a lot of the time. But even if you just think about, for a surgeon to put a patient to sleep, you're billing OR time, anesthesia time, nurse, a whole bunch of people that we don't have in IR when we do our stuff. So in general, yes, it's much more cost effective for IR than open surgery. Anything else? Okay. So resources for you. The best resource for you is going to be the SIR website. The SIR is our national society, international, I should say, society of interventional radiologists. And they have a whole section just for medical students. And there is a ton of good information. If you click on this little blue thing at the top, you get this drop-down menu. And it has all kinds of really good links and documents and things. Sorry, I'm not taking your water. If you look over here on this clinical resources part, and you click on this, there's actually like lectures and outlines of information. What is peripheral arterial disease? What is the central venous line? What is hemodialysis access? And all of this is laid out very nicely for you with stuff that's been written by residents and by medical students. So it's definitely at a level that everybody should be able to understand and follow. This is a new podcast that is called The Sound of IR, and it's also designed for medical students and residents. It's a great podcast. I recommend just checking it out. One of my medical school classmates and residency classmates is a pediatric interventional radiologist in Columbus, and they interviewed her a couple of weeks ago. So it's just, they interview all different kinds of people that do all different kinds of things. It's a really good overview of IR. Another great way to get exposure and get involved is either with your interest groups locally or going to some symposia or some meetings, some IR meetings. We obviously have a IR interest group here. There's a diagnostic radiology interest group here. There is a Southeast Regional IR interest group, which I'll let Paige and Jordan tell you a little bit more about, but that's basically a bunch of medical schools in the Southeast together. And that's part of why we're broadcasting this meeting today, is so that we can sort of share resources and share cases. And there are some places and some schools that don't have big IR departments, and so IR is not a big of a player at their hospital, so they need to see what it's about. There is a meeting in New Orleans on August 25th, so next weekend, which is designed just for med students. And it's a great meeting. Last year was the first time they had it. It's funded by Ochsner Clinic, I think Tulane, Emory. Last year there were people there from Vanderbilt. There's going to be a bunch of, I'm going to go, there's going to be a bunch of program directors there to answer questions about training and cases and showcases and give lectures. There's a big hands-on component to that, so you can see all the fun toys and devices that we have to play with. This meeting is designed solely for med students, so it's a really good way. It's also a very small group of people that go, so it's a good chance to network and meet other people that are interested and other faculty members if you're actually trying to get into this specialty. This meeting in Branson at the end of October is an IR meeting for the regional IR physicians. It has a bunch of private practice doctors, and private practice IR and academic IR are different. So it's good to talk to them and see what they're days are like versus like what my day is like. The speakers at that meeting are from the University of Michigan and the University of Miami. And they're great speakers, and they'll be available to talk to med students. We'll also have a big hands-on thing at that session. That's really awesome. And then the big meeting, which I would encourage you all to go to, is the SIR meeting in Austin this year. It'll be in March. And there is an entire, like you can't imagine, an entire convention center hall where they set up all kinds of equipment. So everybody that sells x-ray equipment and ultrasound equipment is going to be there, and they will have full labs set up. So you can drive the tables around, you can move the equipment in and out, you can rotate the big cameras all over the place. And all of the new toys and devices and stents and balloons and catheters and all the crazy tools that we use will all be there for you to put your hands on. It's free for medical students to attend. Obviously, you got to get to Austin and have a hotel room, which is not free. So there are travel scholarships through the SIR. So you can look at the SIR website and see if you want to apply and go. It is a great meeting, and there are IR doctors from all over the world that come to that meeting. Obviously, last but not least, visit your local IR department, which is me, and Lacey in the back is our program coordinator. I'll give you her contact info at the end. Journals, JVIR is our main journal. It's pretty scientific and research heavy for your level. Tech VIR is a great journal. It comes out quarterly or every other month. And the entire journal will be about 1 month. So.
Sorry.
Okay, that's better. So, like there's a whole journal about pediatric IR, and the 10 articles in that journal will be different components of pediatric IR. In our library, you can get to Tech VIR through our library. Seminars in IR is also great. It's got good overview articles. IR Quarterly is kind of a newspaper thing. What's new? It comes out, I think, obviously quarterly, but it's more news and less research stuff. So 30 seconds about the training program. So how to become an IR. Currently, you do a diagnostic radiology residency, and then you do a 1-year fellowship. And then that's a 6-year program. This is going away in June of 2020, so this will not be available to you. For you, there will either be a 6-year program that you match into out of medical school straight into IR, or you're not sure, so you do diagnostic radiology, and then after diagnostic radiology, either do a 1 or 2-year fellowship. This over here is where it gets confusing and complicated with this ESIR business, so I'm not going to go into detail about that. But just know that it's either 6 or 7 years. You can match straight into IR, or you can match into DR and still get to the end goal. Currently, we graduate about 280, 290 trainees per year. We expect that number to stay the same, maybe up a few, down a few as programs come on board and other programs change the number of people they train, because that's sort of what we think the market needs is a couple hundred new IR doctors every year. It is competitive. It's not as competitive as some of the like super ortho things, but it's competitive. So do well in your classes, get good step scores, do great on your rotations, and then get involved. Go meet people, work on research projects, make sure it's what you want to do. It's certainly attainable. I mean, I'm doing it, so that's a sign that that you can get into it, but it is competitive. Any questions about this? I mean, very brief training program.
You mentioned pediatric IR. Is that a pediatric subspecialty, or do you go through one radiology?
So that is a loaded question. The question is pediatric IR, do you get there through IR or do you get there through pediatrics? So there are lots of fellowships in diagnostic radiology. You can do neuro diagnostic fellowship. So there are 2 ways to do PEDS IR. You can do adult IR and then go get some subspecialty training in PEDS. You can do a PEDS diagnostic fellowship and then get some extra training in PEDS IR. There's a couple of pathways. There's a separate PEDS IR international organization called SPIR, obviously. They have great resources, all that kind of stuff. And Leah Braswell, if you listen to that podcast, Leah Braswell talks about how she got into PEDS IR and what she does. And it's a really interesting field, and there's a huge market for PEDS IR because they don't put very many budgets out. So if that's something you're interested in, that's a great job market. Somebody's mic's on out here. So now we have 10 minutes or so for questions. That's my email address if you want to get a hold of me. That's Lacey's email address, our program coordinator, and that's her office phone number. I don't know how she feels about me sending it out. That's right. She says she's glad it's not her cell phone, which I'll give you if you email me. No, I'm just kidding. Questions? No?
So what about the radiation exposure?
So the question is about radiation exposure. So the question is about radiation exposure in our So we wrote, I have 3 children. I've been pregnant and working full-time in IR with all 3 pregnancies. I wasn't doing diagnostic radiology during any of that time, all day, every day in IR. We have a bunch of female techs also in our department. And so a few years ago, we published basically our radiation dosimeter badges that we wear under our lead for all of the pregnant techs and nurses that had worked in our department and for me. And none of it came close to being concerning. So, and then there have been a couple of papers and articles since then saying basically the same thing. And I mean, you have to wear lead, but it's totally safe. None of my kids are any more bizarro than you would expect related to their genetics. You know, the main radiation concern for IR currently, I think, is cataracts. And so we wear lead glasses. And then the other health concern for IR doctors is actually back problems from wearing the lead. So if you're going to do it all day, every day, you want to make sure you've got lead that fits and lead that's light. There's actually a company that's invented this floating lead stuff. So it like hangs from the ceiling. It doesn't actually touch. Well, I don't know if it touches you. I've not actually seen it. But there are places that have that. So you have no back pain related to your lead. There's really cool things that people are working on related to ergonomics and back pain and all that sort of stuff. What else? Doesn't anybody want to know what this is? Yeah? Okay, good. So I was at Children's one day in IR changing a drain on a little girl who had a hole in her bowel, and this came out with the drain. And this is blue extra bubblegum. And her mom was so upset with her. She was like, I told her she needs to quit swallowing her bubblegum. This is amazing to me. I love this picture. I love the fact that I yanked a piece of bubblegum out on an abscess drain one day. I mean, it's just, she's fine. She did fine. We put a new drain in, but this is what happens when you swallow your bubblegum. In the back, yes, sir.
What's an average step for
I don't know what the last year's data was. Is it out? 250 would be my guess. Yeah, above 240. But, so don't panic. Don't panic, because there's more. at a certain level, you have to be smart enough to learn everything you need to learn and pass the boards. That's a given. But there are lots of other qualities that we're looking for in IR. And if once you're above a certain level, you're smart enough to learn it and do it and pass tests. But I want you to have a great attitude and be a hard worker and be able to talk to patients and get along with patients and explain to patients all this bizarro, complicated stuff we're doing, and be able to explain to referring physicians all this bizarro, complicated stuff we're doing. Because trust me, nobody knows what goes on in IR. It's like this magical place. Patients go in and stuff happens and they come out. Even diagnostic radiologists don't really, I mean, some do, but a lot of them have no idea what we do. So it takes a lot of other skills to be a good IR doctor beyond a board number. And you can demonstrate those skills by rotating on services, your evaluations on your clinical rotations, all that kind of stuff. Yes.
What kind of research is done at UMS specifically in IR?
So the question is, what kind of research is done at UMS in IR? So I have a database where I follow all my HHT patients, and we're working on some interesting drugs to treat nosebleeds. Doesn't involve a procedure at all. Dr. Culp, who's the guy I showed you in that picture, has invented, well, he's actually using something that someone else invented that are little bubbles that help carry oxygen that could be administered in the EMS. So when the ambulance arrives at your house and they think you're having a stroke, they give you these bubbles, and it keeps your brain alive longer in the ischemic part. And he's got lots of funding for that. There are some pharmacology people that are working on some new drugs to treat liver cancer. The transplant surgeons are working on some rejection stuff. The Y90 dosing that we do is a little different than most of the dosing that goes on in the country, and our delivery is a little different. We have some other techniques for sparing parts of your liver. What else? Lots of cost stuff and workflow efficiency things are going on, which is not super exciting if you're a med student, but it's really exciting to administrators. So that's good. Yeah.
Is there a point of contact we should make if we're interested in your research?
Yes. So if you, I assume, are you a M1?
Yes.
So I would try to get into the honors research program at the medical school, and then you can hook up with one of us or somebody else that's doing something that you're interested in. But if you're in the honors research program, then that is also on your CV, and there are a few other requirements for that. But if you can get in, it's a good program, and you know, it's a better way than just trying to do your own thing.
For a lot of us, it's going to be potentially 10 years before we would ever be practicing. So in that time, there's a time where you see the field going, where you see the new horizons and everything.
Oh gosh. So the question is, what's going to happen in 10 years? So the cancer therapy stuff is going to expand. The radioembolization stuff that we're doing is going to move outside the liver for sure. I would expect kidney will be the next big thing. Currently, one of the things that is going on is prostate artery embolization, where instead of getting a TURP, which is kind of a roto-rooter of your prostate through your urethra, we go and embolize the vessels that go to your prostate and shrink it up. The hottest thing that everybody's super excited about is obesity embolization. So it turns out that if you embolize your gastric arteries, you reduce the hormones that are released that stimulate your appetite. So there's lots of research going on about doing gastric artery embolization for weight loss, which is obviously a big thing. What else? I mean, so there are device things, and you go and you see these things and you're like, that is an amazing new, like the angiovac thing. I mean, all of that stuff just sort of pops up. And so I don't know. I think it's going to be more and more and more and more minimally invasive stuff, and less and less and less giant open things. That's not to say there's not a place for all the giant open things, because there absolutely is, but less is more. Sorry, I don't know. You should, so there are people at the SIR that are the big like horizon future of IR people that know all the nitty gritty about national and international research projects that they think are going to be big. So they would be better to answer your question.
Could you talk about the Seldinger technique, just the basics of?
Yes. So the way we do everything in IR is through little tiny holes. So the Seldinger technique is where you start. I've got two things that the people online can see. One set is an 18 gauge needle. This is the old way, or the way people do it where they're not training a bunch of med students and residents. So this is an 18 gauge needle. So you puncture whatever the structure is, an abscess, an artery, a vein with this needle. And then you slide your wire through the needle to hold your place. The needle comes out, the wire stays, and then whatever you want to put in goes in. Does that kind of make sense? Okay, that's called the Seldinger technique. Needle, wire, catheter, sheet, whatever it is. This is a micropuncture set. It's a smaller needle, so if you poke something you're not supposed to poke with it, it's less of a big deal. A smaller wire, this is really probably hard for you guys to see, but it's, you can come up here and monkey with it. But it's the exact same thing. Small needle, small wire, out with the needle, and then in with this little thing that's two pieces. So this is just going to slowly dilate your tract up, and then you're going to take this little part out, and now you can put your big system in. Okay, so that's the Seldinger technique. Is basically needle, wire, thing, catheter, sheet, whatever your thing is. And you can start tiny and go big, like that abscess guy that Paige put all those drains in. We put 18 French drains in, which are big, but we started with this. So tiny to start, big at the end. Okay. Oops, 12 o'clock. Oh, no, it's not. It's 1:45. Oh, okay, awesome. It's like Vegas. What other questions do y'all have? I don't know, do I have any more slides? No, that's our abstract. Oh yeah, for those of you that don't live in Arkansas, it's a spectacular place. This is Lake Maumelle and our Hobie cat and two of my children here. This is one of the few times that this boat is upright. Lots of times it's upside down. And this is the Buffalo River Valley, and this is one of my kids. This is a beautiful, beautiful part of Arkansas if you've never been up there. Okay. Do you guys want to talk about?
Yes.
Okay.
But one more question.
Yes.
So do people routinely do DR and IR? Like?
Yes. Yes. In private practice, people routinely do not do all IR. So the other biggest IR group in Little Rock is at Baptist, and they still do some DR. So they still read studies in between cases. I do almost no DR. I read CTAs, which are CT scans of arteries, but I don't look at chest, I don't read chest x-rays just to get work done. I'm not part of that workflow. But in private practice, yes. And it can be a mix. Some people love DR and they want to do 50% DR and 50% IR. And some people want as little DR as possible or as little IR as possible. So it can be all the way across the spectrum.
What proportion of professional radiologists, like what's the subset size? Is it primarily diagnostic and a lot less interventional, or is there now a lot of crossover, or is it like pretty black and white?
No, it's mostly diagnostic. Lacey, do you know how many diagnostic residents graduate every year?
I know, it's huge.
It's probably 5 to 1. or 6 to 1 at least. IR is a small subspecialty. And then some of those diagnostic people will go get jobs just without fellowships, and others go do a pediatric fellowship or a neuroimaging fellowship or a breast imaging fellowship, or there's billions of diagnostic fellowships. Okay. All right. Thanks, guys.
Thank you so much for your talk. Sorry about the weird sound. Thank you. And thank you to everyone that listened via the live stream. We will send out an email and announce any more meetings that we have. Okay. So while we're ending the live stream, I wanted to say thank y'all for coming. I'm going to send out an email after this, and I will put in a few